Hi, good day, dear colleagues. This is Dr. Jihad, and actually, this lecture is a continuation to the previous lecture when we start to talk about the anorectal physiology. And we said that the anorectal physiology or the function of the rectum and anus differ from the function of the colon. And we said that we have two main function of the anus and rectum. These are the continence and the defecation. And we said that among the workup to figure out any pathology in, for example, in the continence mechanism, such as fecal incontinence, or if we have any problem in the defecation, such as obstructive defecation, among the evaluation of these diseases, we have some tests that will help us in confirming this abnormality. And we said that the fecal that the continence and the defecation is a complex mechanism. That means that many actually mechanisms participate in continence and defecation, and understanding these two functions needs good understanding of the role of the muscle in the anus and rectum. Of these muscles are the internal anal sphincter, the external anal sphincter, the levator and 9 muscle including puborectalis. How, for example, how to test the motor and sensory innervation to this muscle? This will lead us to talk about what we call it the anal manometry. And we said that any change in the anatomy of the pelvic floor will reflect on change in the function of the anorectal region. For example, rectal prolapse will actually reflect in change in the function of these two mechanisms. So we have another parts of test that will focus not on like manometry, not on the sensory and motor innervation, but on the structural anatomy of the pelvic region, such as ultrasound, such as defecography. Defecography can be MR defecography, can be evacuation defecography, or what we call it fluoroscopic defecography. So also we have these tests. We are going mainly in this lecture to highlight on the manometry and how to use it, how to evaluate the results, and also in defecography and the different type of defecography. Of course, not only the anorectal, the anus and rectum present in the pelvis. We have also as we said also in the previous lecture, we have gynecological structure such as the vagina and uterus, and we have also urological structures such as the urinary bladder, and we have tests that will test the function of these organ, but we are going to talk about what test we have to study the anorectal region. Okay, we said that the neurophysiological testing also will highlight on some diseases that are due to alter in the function of the anorectal region, such as fecal incontinence or obstructive defecation. And to be honest, actually, from my own experience, I didn't realize that we have a clear work plan, a clear treatment plan for such diseases until recently, when I started to go deep in the colorectal literatures. And you can imagine that fecal incontinence affects 10% of population. Obstructive defecation can affect 15% of population, and this will negatively affect the quality of life. Pelvic organ prolapse, rectal, urinary bladder, uterus can affect half of paras female. Of them, 15% will be symptomatic, which is a significant number. Of course, we will have a separate lecture talking about these diseases separately. We will talk about fecal incontinence, obstructive defecation, and we will see that the workup with these patients starts with history, and they may come with vague symptoms, and this will require, actually, first of all, if there is a new symptoms, that this will require to rule out more serious diseases, such as if we are talking about fecal incontinence, we have to rule out inflammatory bowel disease. If we are talking about obstructive defecation, we have to rule out first colon cancer. Okay, what else we can add? The neurophysiological testing, which we are going to talk about, the manometry, the defecography, this actually comes as a second line for the investigation or the evaluation of the patient. First, we start with the first line conservative management, such as optimizing stool consistency, either by changing of diet or some medication, or lifestyle modification. Okay, let's move now to talk about manometry in details. Okay, the anorectal manometry, or simply the manometry, actually I prefer, before talking about the equipment, we will talk about when it is indicated, but you can, just for imagination, just to imagine what we are going to talk about. Actually, this is the anometry. We will talk about the difference part, but imagine that there is a pressure sensing probe inserted in the anorectal region. So when do we need anal manometry? As you see in this picture, the main two indications are fecal incontinence and constipation, or chronic constipation, let's say obstructed defecation, anal pain, fissure. We will see how to evaluate the reading of anal manometry, and we will see that fissure will increase the tone of the anus, Hirschsprung disease also. And if we are planning for any surgical intervention in the anorectal region that may affect the continence. For example, if we are going to do fistulotomy, we may need to cut some muscles. So prior to the surgery, we may do manometry, lateral centrotomy, hemorrhoidectomy. In certain cases, we may proceed for pre-op manometry, especially in high-risk patients. If we are going to do rectopexy, also one of the indications to do manometry. Female with obstetrical injury who wish to know what is the quality of the sphincter they have before proceeding to any future delivery. The biofeedback using the anal manometry. And actually, to understand what does biofeedback mean, or biofeedback therapy, it's actually teaching the patient how to properly use their abdominal and pelvic muscle to defecate, and this is guided by the manometry. Actually, I have a nice picture here. You can see this is a nice picture. I bring it from YouTube, and you can see that there is a child with a chronic constipation, and here's a therapist, nurse, doctor is actually teaching him how to use his abdominal and pelvic muscle and the enometrical measurements, the resting pressure and the squeezing pressure, the parameter that is taken from manometry is reflected as a gain. If he push, the fish will eat the bubbles over here. So this is what we mean by biofeedback therapy. So it can help us. This is a nice picture. Also, the main two indication for anorectal manometry is chronic constipation, fecal incontinence, Hirschsprung disease, and we will see how can manometry be reflected, or how Hirschsprung be reflected in anal manometry, evaluation of function of anorectal pain, biofeedback, which is shown here, assist patient before any intervention such as we said, rectopexy, hemorrhoidectomy, fistulotomy in a high-risk patient. Of course, the contraindication we will see when we will talk about the equipment now, that it requires insertion of a pressure sensing probe. So one of the contraindication is anal stricture or obstruction. What else? Let's move to the equipment. Okay, the equipment, or how do the manometer looks like. And one of the interesting information that the anal manometer were done first in 1877, and at that time, due to or with the help of manometer, we detect or we find that we have what we call the rectoanal inhibitory reflex, which we will talk about today, because one of the parameter that we can detect using manometer is the rectoanal inhibitory reflex, and we talk about it in the rectoanal physiology. Actually, we have many forms of anal manometers, the traditional, more classic type, and the more advanced type can be classified according to the probe itself, but actually they consistently consist of a pressure sensing probe. This is a nice picture, shows you that here we have a pressure sensing probe, comes in many models and techniques. We will talk about them. And we have also the recorder. Here is the recorder, which according to the frequency detect the change in the pressure. And we have simply a video monitor that will display, which will show us the differences in pressure. Actually, to make it simply, we have two types of anal manometry: the conventional, the traditional, the classic type, and these are the water perfused, using the water, and the air charged. And we have the more advanced, the what we call them, the solid state catheter. Solid state catheter can be either the high resolution or high definition catheter. What do we mean by that? Actually, if you see in this picture, we have the traditional one. Here we have the display, here is the monitor, here we have a syringe that will inflate a rectal balloon. This balloon, actually it's not seen here. Here we have actually one single balloon in the rectum and 4 balloons in the anal canal. And we inflate the rectal balloon, and we will change the resistance or change in the pressure in the anal canal indirectly by changing the resistance in the balloon that are located in the anal canal. This is another type of more advanced, or what we call it, the high resolution anal manometry. Only we have a rectal tube. We have no balloon in the anal canal. What we have in the anal canal is a sensors, and when we inflate the rectal tube, actually there will be a change. When we inflate the rectal tube or we distend the rectum, there will be a change in the anal canal pressure, and this will be sensed in these sensors and will be reflected on a monitor. Okay, the number of these sensors and how do they are oriented is important. We will see now. Just your patience to review how do water perfused catheter. You can imagine this one, water perfused. Actually, okay, the water perfused, when we compare it to the more solid type or the high resolution or 3D probe, it's lower cost, cannot be used in upright position. And we said we have balloon in rectum for balloon or lower sensor in the anal canal, and this will limit measuring the pressure of the anal canal at one time. So what we need is to pull through the manometer and to detect the change in the pressure through the whole anal canal. This is called pull-through procedure. This is not required in other type. For example, in solid state catheter. This is one of the disadvantage because pulling the probe may cause artifacts. Okay, we said that it indirectly measures the change in the pressure in the anal canal by changing the resistance in the balloon that present in the anal canal. How we water perfuse it is by installing 0.2 to 0.4 milliliter per minute. Require calibration, of course. Conventional manometry, by the word conventional manometry, we means that we only have a few sensors. We said, for example, in this picture, the conventional one or the water perfused, we said we have rectal balloon. We have 4 rectal balloon. Inside each balloon, we have sensors, but they are few. They are only 4, for example. And we said due to the limit of the number of the sensors, it require to pull it to detect pressure along the canal. What else we should know that these are called conventional manometry probe, or what we call them the water perfused, or sorry, for example, the water perfused. They are few sensors and incapable to detect pressure through the entire anal canal, so it require pull through and rotation. They are not radially oriented well. They may be, you will see a picture here. I think we have a picture here for water perfused. This is water perfused again. You can see here that we have sensor 1, sensor 2, sensor 3, sensor 4, and they are oriented. You can see we have at each row we have 4 sensors. So, and they are covered by balloon. So they are not well oriented. When we compare it to conventional, you will notice that up to 250 sensors we have in the high resolution, we will show. So these are limited, so it need to pull through, to pull that, to change it, to rotate it, to detect the pressure in the anal canal. Okay, this is the conventional. We said they are poorly radially oriented when we compare it to the solid state, as we will see, and require pull-through procedure. This pull-through procedure will cause artifact. The solid state, which we will show you, just to imagine what do we mean by solid state. This is the solid state. Imagine how many sensors are oriented here. Also here you can see we have 16 rows, and each row have 16 circumferentially oriented sensors. So we have up to 256 pressure sensors. Do you imagine what do we mean when we say that we have few sensors in the water perfused catheter? But of course, there is a disadvantage. Solid state catheter, they are more expensive, they are fragile, they need less experience because it does not require the bullet throw procedure. What else? The accuracy is higher, calibration is easier, and it's easy to use actually when we compare it to conventional. They just compare a water perfused catheter and a solid state catheter, and actually what I want you to concentrate on, that there is the water is cheaper, durable. The solid, we said that they are fragile, and warranty for few hundred procedures only. Okay, the other parts is related to the upper GI. Air charge, one of the conventional one. I think we have a picture for air charge. This is water perfused. Okay, we said here we have sensor. This sensor for the rectum. These sensors in the anal canal. Here we have a balloon. And here also we have a small balloon. Okay, and here how do the sensors are radially oriented. This is, I think, the air charged manometry. What information should we know about the air charged catheter? Uses air column from the balloon to external transducers. Okay, low cost, disposable, no need for disinfection, reproducible result. This make the water perfused better when we compare it to air charged. Here is the cath or the sensing probe are classified to water perfused, air charged, and solid state. Solid state are two types: the high resolution manometry and the high definition manometry. As you see in this picture, this is the high resolution manometry. You can imagine we talked about that up to how much, or the high definition, the high resolution, how many sensors we have. You can imagine. Sorry. This is the high definition, actually up to 256 sensors we have. They are oriented. They do not require bullet throw because all the probe covered with this is how the resolution, how you will see with the high resolution, I think, high resolution, the 3D. We said that we have two types for solid state. These are the high resolution and the 3D. The high resolution actually comes first in 2008. Few years later, we have the 3D manometry and topography. What I want to alert you that the high definition or the 3D, you can see the results we will have in the monitor display. They are colored and of course different from these results. This is how the conventional results looks like. Okay, we will talk about the e-sleeve, but let's talk a little bit. Did you imagine this is the high definition and this is the high resolution? Okay, just when we compare the high resolution, RAM called invented a few years ago, 2008. We have the high resolution actually not full of sensors like the high definition. You can see 2 sensors in rectal balloon and 10 sensors at 6 millimeter interval at the anal canal. While the high definition, you can imagine 256 sensors in 16 row. Each row have 16 sensors. So the high definition clearly it's more advanced and give you a topographic image, colored image, imaging. Um, okay. Okay, what we else want to say regarding the high resolution, for example, the high definition, larger diameter. We have a instrument called the E-sleeve. Actually, you can imagine that many data comes from the sensors to the monitor. So this instrument analyzes the result with low error result and will give you final result. This is the rule. Decrease data from number of sensors into a single max value and will give you the best results. This is what we call it the E-sleeve. Reduces data from number of sensors into a single maximum correct value to each time point. It's like analyzing the result. Okay. I hope that we discuss most of the thing. Again, let's review. We have the conventional few sensors, for example, water perfused. This is water perfused. For example, air charged. These are traditional. And we have more advanced, the high definition. This is the high definition. High resolution. High resolution. We have, as we said, two sensors in the rectum and 10 sensors in the anal canal. We have no balloon here. We have balloon in the rectum that cover the sensors actually here. And we have the high definition probe. This is the result of the high definition probe. Okay, I hope I didn't miss any information. Let's move to the technique. How should we perform manometry? Okay, how to perform the manometry? Actually, first of all, we need bowel prep? And the answer, no, it's optional. But what we need is a clear anal canal, relatively clean rectum, 30 seconds before the exam. This can be done with phosphate enema, with water tap, and before starting we have to do PR to detect any local pathology, to check the anus is clean, and no fasting is required. The patient is positioned in the left lateral position with the hip and knee flexed. And before starting, we should share the common language that we need with the patient. We should tell him what do we mean by squeeze, what do we mean by stimulating the defecation. So we should explain or give some instruction to the patient. The probe, when we insert it, it should be lubricated, but preferable non-anesthetic agent, because some anesthetic agent can alter the our results. Of some intraoperates, especially children, can be even done under GA, but in this situation we will lose some parameters that we can take from the manometry. For example, the rectoanal inhibitory reflex can be done in some cases under general anesthesia, but it's preferred, of course, with if the patient is conscious to our instructions. As you see here in this picture, here is effect of anesthesia. Anesthesia indicate anesthesia indicated in intraoperative children patient, and anesthetic agent, some anesthetic agent are not affecting the rectoanal inhibitory reflex. So some agents such as midazolam, sevoflurane, nitric oxide, desflurane, propofol, thiopental, this doesn't affect the reflex. But ideally, to perform it without anesthesia, even the probe should be lubricated without anesthetic agent. But some anesthetic agent can, of course, such as anticholinergic agent, can inhibit the rectoanal inhibitory reflex. What else we have? When we place the pressure sensor probe, we said we have different models, but what we should keep in mind that the last sensor should be seen at the anal verge. This is one. The balloon, we said that we have a balloon in the tip that should be placed in the rectum. So it should be at least 4 to 5 centimeter from the upper anal canal, from the anorectal ring, so to ensure that it is in the rectum. What else we need? That we need, when we record the pressure, we need to record it along at least 6 centimeter. This way, sorry, stop the video for a second. As we said, we talked about the anal length. We should measure at least pressure along 6 centimeter, and this can be done with the polythrow technique. The polythrow technique, we have stationary polythrow technique or continuous polythrow technique. Actually, to explain for you, we said this depends on the probe. Again, if the probe have a few sensors, we have to pull through. Continuous means pulling the probe without stopping, and actually stationary polythrow, pulling, waiting for minutes, then pulling and wait till recording. We will talk about that. This depends on the again in the model of the probe. I think we will talk about it right in the next few minutes, seconds even. Okay, what we have after probe placement, we should give the patient time to rest for 3 to 5 minutes. This will actually allow the sphincters to relax and allow any anxiety-induced pressure and the normal value to return to normal. When we insert the sensors tube, we may detect two wave activity. The first one is the ultra slow wave. The second one is the slow low amplitude wave. So we have ultra slow and slow. The ultra slow actually with high amplitude, the slow with low amplitude. Ultra slow wave that we may detect can be normal variant, rarely associated with other disease. This is upon insertion or the first detectable wave activity. The ultra slow wave, actually they are less than 1 to 2 cycle per minute, while the slow wave is up to 10 to 20 wave per minute. They are more common. The ultra slow wave of unknown significance, actually, yes, they are normal, more common in male, unknown significant, may be associated with other diseases, but they are not with a high sensitivity and specificity. The low amplitude wave, we will see it now. We said they are more frequent, 20 seconds. They are normal variant. They may, their significance, that this contraction, mainly in the internal anal sphincter, and will allow the stool to be pushed back toward the rectum, and they participate on the continence mechanism, promote anal continence. We talked about the pull through technique and how to measure the length of the length of the anal canal. And this is actually depends on what type of a probe do we use. Do we use the conventional, the few sensor, the water perfused, the air charged, or we use the more advanced one, the solid state, the high sensors, the high resolution, the high definition? Okay, if we use the first type, water fused or air charged, we have few sensors. So to detect the pressure along 6 centimeter, we have to pull through. Pull through can be by two type, either continuous pull through and the pressure will be detected in 1 centimeter interval every 1 second, or this is the continuous, or what we call it the stationary technique. Stationary technique means pulling and stopping. This is wrist and squeeze pressure are detected at 6, 5, 4, 3, 2, 1 centimeter interval. We pull 1 centimeter and we stop, not one time. We pull and stop. This means stationary technique. Actually, the stationary technique is preferable when we are talk about the conventional. We will see regarding the the solid state. The stationary pull through technique is preferable because it is associated with lower reflexes. You see, reflex sphincter contraction resulting in high. The continuous pull through is associated with reflexes, more reflexes and more artifacts. Okay. The solid state, we said many sensors, so we do not need the pull through because the sensors is all along the anal canal. So stationary technique, it's short time of the exam, short time during the exam, and we will detect the pressure along 6 centimeter. In another word, the length of the anal canal. Regarding what's comfortable for the patient, what's proven that there is no difference between the water and air charge and the high resolution, but the high definition, if you remember the topographic imaging, the high definition which gives you the colored imaging, is proven that it's more comfortable than the three previous method. High definition is better than high resolution, or comfortable than high resolution, than air charged, than water charged. What else we have? I think I have to show you a picture. This is the ultra slow wave we talked about. We detect directly after insertion. We said they are of unknown significance, more common in male, 1 to 2 in 1 second. High amplitude, by the way, more than 40 mmHg in normal patients and other pathology, but they are not sensitive. Actually, we have a criteria to diagnose them. Of this criteria, this than 2 cycles per minute, amplitude high more than 40. The slow wave, more common, 10 to 20. Normal significance, they may push the stool up and participate in continence. This is the stationary pull through. We say we pull every 1 centimeter and we detect the pressure. Now we are going to talk about what parameter we will detect in anal manometry. Of these, you can watch here. Actually, the anal manometry is still developing, and as you see, we have lack of standardization. The standards is not well developed and actually we would see the London criteria that is try to do a fixed parameter that should be measured every anal manometry. But in general, we have to check when we do anal manometry the anal canal resting pressure, first of all. Second, the length. Third, the squeeze pressure. So, rest, length, squeeze, cuff reflex. We have to detect the what we call it the stimulated defecation or peer down maneuver. We ask the patient to stimulate the defecation and we measure the pressure. We check in anal manometry the recto-anal inhibitory reflex. We check the rectal sensation, which is an important. The rectal sensation, when we talk about the rectal compliance and rectal sensation in the physiology of the anal canal, we said some patient may lose the rectal sensation and megacolon can develop. And rectal sensation, we will see that should be detected at the first sensation, the sensation when we desire to defecate, and the sensation with maximal tolerable volume. We should check the rectal compliance, how we will see how to check the rectal compliance. And with the use of anal manometry, we have the rectal balloon expulsion test. Actually, it is a balloon that we insert it in the rectum and we ask the patient to defecate, and we would see how many time he take or the duration he take to expulge or to evacuate this balloon. These parameter, first let's talk about the resting pressure and its significance. Okay, apart from the slow and ultra slow pressure which are detected when inserting the probe, the first intentionally measured pressure is the resting pressure. Then we go to the squeeze pressure. Okay. First of all, we have to know that the resting pressure or the anal canal is in a state of tonic contraction. It is contracted in a normal situation. The resting tone is due to the internal, external, and to a lesser degree to the hemorrhoidal plexus. So when we measure the resting pressure, we are measuring the function of these items. The internal anal sphincter up to 55, no, it's a little bit higher. External anal sphincter up to 30 of the anal resting tone, and hemorrhoidal plexus to 15 of the anal resting tone. Okay, of course we said first thing before we measure the resting pressure, we should give patient time to relax. So after 3 minutes to 5 minutes, and then we record. After proper positioning of the probe, we start recording the pressure over 30 seconds approximately. We have to detect the maximum resting pressure we will have, or the highest pressure of at any time during these 30 seconds, and we should measure, while measuring the resting tone, what we call it the high pressure zone. In other words, the anal canal length. The high pressure zone, actually it is the length of the anal canal with the pressure more than half of the maximum resting pressure we detected. The high pressure zone usually in male from 2.5 to 5 centimeter, and in female usually 3 to 4 centimeter. It's shorter in female. What we have to keep in mind that the resting tone is lower in female plus lower in older female. when we compare it. So it decreases with age in female. Any problem in the resting tone will lead to what we call it passive fecal incontinence. Unconsciously soiling will happen, or what we call the hypotonic resting pressure. Hypertonic is associated with many diseases such as fissure. Fissure will cause actually scarring, fibrotic tissue, and will cause hypertonic pressure, resting pressure, and constipation. Okay, what is regarding the resting pressure else? Okay, this is how to the interpretation of the resting. Normal resting pressure, we said that it is low in women, low in older female. If it's increased, what does this mean? That the small muscle or the striated muscle, because we said the resting pressure is due to the external, internal, plus the hemorrhoidal plexus. So if it's increased, it can be due to the smooth muscle, internal, striated muscle, external muscle. It can occur in fissure or idiopathic anal pain. Decreased pressure, we said this is hypotonicity, can be, for example, due to sphincter injury. The length of the anal zone, usually 2 to 3 in female. Okay, we said 4, it's 2 to 3, and in male it's 2.5 to 3.5 centimeter, a little bit larger or longer. Squeeze pressure. The squeeze pressure, again, it measures the voluntary muscles or the external anal sphincter. Again, we measure the squeeze pressure over 30 seconds. We repeat this maneuver 3 times and we take the maximum value. We measure 2 things. These are the maximum pressure and the maximum squeeze pressure and the duration of the sustained squeeze pressure. This is the maximum squeeze pressure, and this is how much the patient can sustain squeeze pressure. Okay, this is the maximum sustained pressure. Below this, the patient get fatigability, and we say that the fatigability of the external anal sphincter is more than the internal anal sphincter. So we are checking what else we want to add regarding the squeeze pressure. We said that we have to check maximum. That means asking the patient to maximally squeeze as hard as possible, as long as he can. As hard as possible, this is the max. As long as he can, this is the sustained squeeze pressure. This again, the squeeze pressure or the external that reflects the external anal sphincter pressure is lower in female, lower in older female. Okay, actually the normal value, we have to remember that it is lower in woman and older female. Increased maybe due to problem in the external anal sphincter, fistula, pain, abscess. Well, of course, you are not going to do manometer for abscesses, but you have to understand what do we mean by squeeze. Squeeze means external, so you have to analyze why the external may increase in pressure. Here they said that chronic pelvic pain may be associated with chronic pelvic pain. Decreased squeeze pressure means decreased function of external anal sphincter, so we may have sphincter injury with variation in the sensitivity and specificity one of the nice information regarding the sensitivity and specificity, that sensitivity is ability to detect the disease, while specificity the ability to rule out the disease. If we have the sustained pressure decreased, that means the external anal sphincter of the patient tired too fast. Fatigability of the external anal sphincter is high. So if it is less than 10 seconds, so this may lead to incontinence to liquid stool. We said in the internal anal sphincter, passive fecal incontinence. Cuff reflexes. Okay, before going to cuff reflexes, what I want to pay your attention to is that if you notice that in the squeeze pressure, the rectal pressure remains the same, does not change. And this is logic. Actually, when you ask the patient to squeeze, this means that please keep the external anal sphincter contracted to maintain the continence, to prevent the defecation. So, if the rectal pressure or intrarectal pressure increase, that means that this patient is using, to keep the continence and to prevent the defecation, is using his abdominal muscle, his accessory muscle. And this is maybe an indication to refer the patient to biofeedback, to teach them how to use his muscles, abdominal and pelvic muscles, separately. Okay. Regarding the cuff reflexes, actually, after measuring the wrist pressure, the squeeze pressure, we ask the patient to cuff and to repeat this cuff after 30 seconds, and the cuff actually will lead to sudden increase in the intra-abdominal pressure. And actually, logically, that the external anal sphincter will contract to prevent the defecation or to maintain the continence. And also the intrarectal pressure will increase, because when you cuff, you increase your intra-abdominal pressure. So as you see here, this is the normal cuff reflex. The rectal pressure increases, the anal pressure increases. What happens if it does not increases or low? We start to talk about, or absent cuff reflexes, we start to talk about lesions in the sacral root, not in the level of the external anal sphincter, in the sacral root, or lesion in the pudendal nerve. So this may indicate pudendal neuropathy. If we have, for example, low squeeze pressure, this means that we have a defect below the sacral root, or at the level of the pudendal nerve, called a defect in the sacral reflex arch, such as patient with cauda equina lesion. Why we are saying that? Because above this level, above the sacral level, the cuff reflex is preserved. So any lesion below the sacral level, any lesion in the pudendal nerve will cause absent cuff reflex, and you see here that the rectal and the anal pressure will increase. Push stimulated evacuation. Okay, after finishing the cuff reflex, we go to push or stimulated evacuation. We ask the patient to mimic as if he is going to defecate, and we detect the pressure. And logically, if you look here, that the normal simulated defecation require what? Increase in the rectal pressure and decrease in the anal pressure. This is the normal. This is the high definition, which we said high resolution or high definition. The color should be high resolution. Okay, high definition anal manometry, and you see here that the rectal pressure is increased, the green one, and the anal pressure is decreased here. So this is the normal response. In the second picture, you shouldn't be professional in analyzing it, but it's clear that here the red zone increases, which means that there is an increase in the anal pressure, which is a not normal defecation mechanism. This will lead us to start talking about what we call it the dyssynergic defecation, or inability to defecate, no power to defecate. This is maybe due to, we said that the rectal pressure should decrease. So this is maybe due to non-increase of the rectal pressure. We have inadequate push. The rectal pressure due to increase in the intra-abdominal and pelvic pressure. Or this is maybe due that the anal pressure does not relax. It is, we have contraction, spontaneous contraction, or while defecation, or inability to relax. The same, either contracted, inability to relax. This will create a dyssynergic defecation, inability to defecate. Actually, dyssynergic defecation have many, as you see here, many names for the same disorder: dyssynergic defecation, anismus, paradoxical puborectalis contraction. Actually, these are different mechanisms, but under the name dyssynergic defecation. The normal defecation require increased rectal, decrease anal pressure. Any change in the rectal pressure, if it doesn't increase, this means inadequate push. Anal does not decrease, this means inadequate relaxation or paradoxical contraction. This will lead us to start talking about the four mechanisms of dyssynergia or dyssynergic defecation, as you see here. Type 1, it's logic. The rectal pressure increased, this is required. Adequate push effort, nice. While there is a contraction of the increase in the anal pressure, so there is a contraction, a paradoxical anal contraction. So this will lead that the anal canal is closed. There is no defecation. You can see that both are increased, while here the normal one, the anal should increase, it should open. Okay. If we go to type 2, for example, also again, we have no increase in the rectal pressure while asking the patient to defecate. This means that impaired push effort. And what else? We also have paradoxical anal contraction. So they synergize each other. What else we have? Here, for example, we have adequate, type 3, adequate rectal, adequate push effort, but the anal canal failed to relax. We say that the anal tone is in a state of tonic contraction. So either it contracts more or it failed to relax. Defecation requires relaxation. Here it increased. As you see here, what here? Type 4. We have impaired rectal pressure, not enough push effort. What else we have? Impaired anal relaxation. The anal relaxation is not enough. Different type of dyssynergia. The problem that, as we will see, that the manometry cannot alone diagnose dyssynergia. We will see why. So we said that evacuation require what? Increase in rectal pressure, decrease in the anal pressure. The patient is asked to push down as if he want to evacuate. Actually, this is done in 3 times, 2 interval. First interval 30 seconds, first interval 15 second, first time we wait 15 second, second time we wait 30 second, then third time, and we use the best attempt for analysis. In this case, the sensors is inside. We do not need to inflate the rectal balloon. We can inflate it, we cannot inflate it, different, but it is not required. As we will see in the rectoanal inhibitory reflex, the mandatory to inflate the rectal balloon, where in push stimulated evacuation we do not need. The types, okay. As we said, manometry cannot alone diagnose this synergic defecation. Why? Because 90% of asymptomatic patient gives this pattern. Actually, you will find this synergic pattern in anal manometry in asymptomatic patient. Actually, why? This is maybe, first of all, the position. The patient is in the left lateral position. He is actually not adequate for evacuation. It's not the usual, the normal positioning for the non-physiological positioning for evacuation. The second, the rectum may be empty, so he cannot simulate defecation. Okay, we have many gradients. For example, the rectoanal gradients is the difference between rectal pressure, which should be high, and the anal pressure, which should be low. If it is negative, that means the rectal pressure is low, the anal pressure is high. This means that this is dyssynergia. Okay, the defecation index, maximum intrarectal pressure, and the anal pressure. Actually, okay, before going to rectoanal inhibitory reflex, let's review. We reviewed these, we talked about these. Also, indication for anorectal manometry in dyssynergic defecation. These patients will come with symptoms of constipation, and the first line is not to go for anorectal manometry, but after failure of the diet modification, lifestyle modification, the laxative therapy failed, we go to anal manometry. That will help us with also the use of barium enema to study and to complete evaluation of the synergic evacuation. Okay, what else we want to add regarding stimulated many names, as we say: stimulated defecation, peer down maneuver, push, what's the push defecation, evacuation, stimulated evacuation. These are the same actually. And peer down maneuver. What else? Normal. Okay. Let's go to the rectoanal inhibitory reflex, the rare. Okay. Rectoanal inhibitory reflex actually discovered after when we start using the anal manometry. We said that we insert a pressure sensing tube with a balloon in the tip that should be in the rectum, should be 3 to 5 centimeters above the upper edge of the anal canal, so it's in the rectum, and we distend. So we distend this balloon, and when we distend this balloon, actually distension of the rectum will happen. This will lead to contraction of the external anal sphincter, or which cover or engulf the distal anal canal, will be contracted. Okay, and the proximal anal canal, which is, in another word, the internal anal sphincter, will be relaxed. So again, distension the rectum, constriction or contraction of the external anal sphincter, relaxation of the internal anal sphincter. This will allow the the content of the rectum to reach the proximal anal canal, and at that level we will decide to go to bathroom or to keep, if it is socially unacceptable, to not to defecate, to keep the maintenance. Actually, the rectoanal inhibitory reflex occurs every 10 minutes, 4 seconds, and the rectum will accommodate, will distend more and more and more. And we said you have to be aware of the desire. If there is desire, please go, because the rectum have the capability to distend up to megacolon. And okay, on manometry, how is this detected? Actually, this is detected by increasing the rectal pressure will cause decrease in the resting pressure. We said the internal anal sphincter will decrease, so the resting pressure will decrease, or the internal anal sphincter pressure will decrease. You can see here that the rectal pressure increase, the resting pressure decrease. The resting pressure, the internal anal sphincter relax, so decrease. I think we have a better photo. You can see here, for example, this is a photo shows you how do we this is actually related to the volume of the balloon. How much, the more we inflate the balloon, the more the resting pressure, or the more the internal anal sphincter will relax and the resting pressure will decrease. You can see here, we inflate the balloon, or we distend the balloon with 10 cc water, the resting pressure decreases a little bit. And this is called the rear reflex. Here, 20 more, 40 more, 50 more. This is actually occur due to the myenteric plexus located in the rectum, and absence of the rear reflex may be due to hair-shaping disease. As we know, we will talk about it. Again, please look at this picture. We distend the rectum. This is the rectal pressure. We distend it. And what happens to the anal pressure or the resting pressure? It decreases. After a while, it will return to the normal, as you see here. We distend the rectum, the anal pressure decrease. We distend the rectum. You can see that it depends on how much you distend the rectum. Okay, before going, we have a nice picture here. The rear reflex. We said rectal distension will cause reflexive contraction of external, in another word, the distal anal canal, and relax of internal, in another word, the proximal anal canal. This is by the myenteric plexus. Sometimes we may fail to elect the rear reflex. This is maybe because we have a huge rectum, so we need to use more water to inflate, or this is because of we do not give volume enough. So what's advised is to repeat the test with more distension of the balloon. Absent in hair-shaping disease, for example, in patient who had what we call it acquired myenteric neuropathy. This is due to the myenteric plexus, so myenteric neuropathy, and after rectal reconstruction, after proctectomy, the rear reflex will be inhibited. What additional information we want to add? Actually, we already talked about if we have no rear, even after distension of the rectal balloon with more volume, so we are talking about hair-shaping disease, a type of myotomy, circumferential myotomy, post-circular myotomy, we remove the myenteric plexus. Low anterior resection, if we are talking about large volume needed to elect or to reach the rear reflex, so we are talking about mega colon. The colon is huge, so we need a lot of water, a lot of inflation to increase it. So megacolon, Chagas disease, rebound. It's not matter. We do not want to discuss this. This is Hirschsprung disease, and you can see normal child increase in rectal pressure causes decrease in anal pressure. Again, increase in the anal pressure causes decrease in the anal pressure. This is a normal. While here in Hirschsprung disease, this is both called the rear reflex. While here you can see increase in the rectal pressure. This is depend on how many volume we give. Doesn't cause relaxation of the proximal anal canal. Doesn't cause relaxation of the internal anal sphincter. Okay, actually, if we are not going to discuss Hirschsprung per se today. We will have a lecture about pediatric colorectal disease, but you can see that to diagnose Hirschsprung disease, the best is to use rectal suction biopsy. I think that most of you familiar with that. Then we have the anorectal manometry, which have a good sensitivity. If you look here, the suction biopsy carries 93% sensitivity, and the anorectal manometry carries up to 91 sensitivity, and contrast enema 70. Okay, let's move to rectal sensation. Okay, one of the parameters that we can study using manometry is the rectal sensation, and we said that when we use the manometry, there is a balloon at the tip of the probe which should be positioned correctly in the rectum, not distal in the anus. So if it's in the anus, it will give us a false reading. I have this picture. It should be 3 to 5 centimeter proximal to the proximal anal canal. If it is low, it will be restricted between the sphincter and will give us a false reading. And actually, when we talk about the rectal sensation, this will lead us to talk about the compliance of the rectum. We said that the rectum have the ability, when the volume inside increase, to distend up to large volume. So this enlargement due to the increase of the continent called the compliance, when it is stretchable actually. So when we study the rectal sensation, we actually have also to record 3 sensation threshold. We inflate or insufflate the balloon with air, and we ask the patient to tell us 3 sensations. The first sensation, when he first feel that we are insufflating. The second, when he first feel the desire to go to bathroom, or the urge to go to bathroom, and we record it. The third, when he maximally can tolerate, we give more, and when he maximally can tolerate the inflation of the balloon, and we record it as you see here. This is the maximum tolerated volume. We record it. As you see that when we increase the volume of the balloon, or we are mimicking that there is stool in the rectum, actually the pressure will increase. This is logic. The pressure will increase for a while, then it will come to a steady phase. This is because of the accommodation, the compliance of the rectum. The rectum will distend. So the relation is not linear, but as you see here. Okay, this also will lead us to talk about what if we have hyper or hyposensitivity. If we are talking about hyposensitivity, this means we are increasing the volume, but the pressure is not increasing. This may be caused by constipation. Okay, well, the volume is increasing with the stool, but the pressure is not increasing. The patient have megacolon, for example. So this is maybe chronic constipation, or the patient is having colectomy. The vice versa, if we inflate the balloon a little bit, but the pressure increase dramatically, this is hypersensitivity. This is maybe due to ulcerative colitis. The patient cannot wait. Inflammatory bowel disease, diarrhea predominant. A low anterior syndrome, urge fecal incontinence, radiation proctitis. Also, the compliance and the sensation can improve after we send the patient to biofeedback. When he come back, we can use the anal manometry and rectal sensation and accommodation and compliance to check if we have good result after biofeedback. Again, this is what we talk about. If we have rectal hypersensitivity, little bit volume, high pressure, that means that we have urge incontinence, proctitis, inflammatory bowel disease. While if we have rectal hyposensitivity, we are increasing the volume with no change in the pressure. So this patient may have a defecatory disorder in a form of constipation, megacolon, etc. Okay, what else we want to? The normal rectal compliance, which is the change in the pressure, the relation between the change in the pressure and the change on the volume and the change in the pressure is about 10, 12 mmHg. Okay, what else we have? What else we want to add? This is also interpretation of the rectal compliance. You can think with it as we think in the sensitivity, hypo and hypersensitivity. For example, reduced rectal compliance. That means it's not distended. The rectum is not distended well. So this is will be reflected how in anal manometry. Reduced rectal compliance. We are increasing the volume and the pressure increases rapidly. So this is hypersensitivity. Diarrhea predominant, the same as diarrhea predominant inflammatory bowel disease, inflammatory rectal disease, ischemic the disease of the rectum, pelvic irradiation. While increased rectal compliance, the rectum, we are giving volume, but the no change in the pressure. So this is hyposensitivity, such as in megacolon, constipation dominant, inflammatory bowel disease. I think the last parameter that we can study with the help. Oh, this actually doesn't require the manometry. The balloon expulsion test is one of the physiological tests of the anal rectal region and pelvic floor. Okay, the balloon expulsion test, I think I said expulsion test, or PET. Actually, it's simple. Actually, what we do is it has no relation to anal manometry, but it's done at the time of doing anal manometry. What we do is we insert a balloon inside the rectum of the patient. We fill it with 50 cc water approximately until the desire to defecate to start, and we ask the patient to go to bathroom and privately evacuate the balloon. As you see, this is the anorectal expulsion balloon. This is the balloon. It's connected with catheter because some patient will not be able to evacuate it, and we can after that empty the balloon and remove it. We insert it, we fill it with 50 cc. The normal time to the patient to evacuate the balloon is about 1 to 2 minutes. Okay, so it is mainly used to screen for obstructed defecation. Actually, it has a low sensitivity, low specificity. Actually, it's a developing test, not till yet clear when to use, when not to use. As we said, a balloon filled with 50 milliliter warm water. The patient then asks to go to the bathroom and pass it privately. More than let's say it's normal within 1 minute. More than 1 minute, we start to talk about obstructed defecation, dysynergia, and actually what else we can add regarding the balloon expulsion test. Okay, let's move to London Protocol and Criteria. Okay, the idea behind London Protocol and Criteria, it's actually to make a standardization for the manometer. Actually, the previously reviewed parameter can differ from one colorectal surgeon to another, from one gastroenterologist to another, and they actually try to make clear standards when we perform anal manometry, similar to Chicago classification of esophageal motility disorder, and these consist of the 4 part of London classification: disorders that is associated with the rectoanal inhibitory reflex, for example Hirschsprung disease; disorder that is associated with anal tone and contractility, when we talk about the pressure, the squeeze pressure and resting pressure; disorder with the rectoanal coordination, when we talk about simulated defecation; and disorder of rectal sensation. We have to check these disorders when we perform anal manometry, and they said that there is a major criteria that shouldn't be in a normal patient, and there is a minor criteria that may be present in a normal patient. For example, absent anorectal inhibitory reflex, or rare, is a major criteria. Hypotension and hypocontractility is a major criteria, which may lead to fecal incontinence. Rectal hyposensitivity, which may lead to constipation, also a major criteria, and hypersensitivity. So rectal hyposensitivity and hypersensitivity is a major criteria, whereas anal hypotension and hypocontractility is a major only. The anal hypertension is a minor criteria that may present in normal patients. Dysynergia can present, we said that dysynergia can present, and the synergic pattern of anal manometry can present in asymptomatic patient. Should we repeat them again? Absent anorectal inhibitory reflex, anal hypotension, rectal hyper or hyposensitivity. Minor criteria, these are anal hypertension in a normal patient. Dysynergia can present in a normal patient. Here just they reviewed the author's note or idea about, they compare the conventional and the high definition and 3D manometry. Actually, they advise, according to their experience, the air charged conventional traditional manometry, because it is cheaper, easy to use, etc. It's not the subject to stop and just here a nice photo at the end of the discussion of anal manometry, the result how to interpretation of the anal manometry. We said it's like the conclusion of the anal manometry part of this lecture. You can see here are the tests and what does they reflect and what do they mean. For example, resting pressure, we said it assess internal anal sphincter. If it is decreased, so weak and disrupted internal anal sphincter. If it is increased, the resting pressure increased, this means either the internal or the external anal sphincter have spasm. The squeeze pressure responsibility of the external anal sphincter. Okay. Decrease means weak external anal sphincter. It could be myogenic or neurogenic or non-compliance. Decreased squeeze pressure. This may lead, as we said, to incontinence, to liquid. When we said decreased resting pressure can cause passive fecal incontinence. Cuff reflex means screen damage to the sacral reflex arch, and we said that the cuff reflexes will be absent if there is abudendal neuropathy and if there is a lesion below the sacral root. Decrease the anal resting pressure, normal response increase. Okay. Rectoanal inhibitor reflex, we said that this is in Hirschsprung disease. We screen for Hirschsprung disease. Sensation, we said either the sensation is decreased, hypersensitivity, or increased in hypersensitivity, decreased such as hyposensitivity, such as in irritable bowel syndrome, diarrhea, predominant urge, incontinence, proctitis. The patient cannot tolerate to toilet. While if we have increased sensation or hypersensitivity, this may lead to defecatory disorder. Balloon explosion test, this may test dysynergia and also the defecation problem, obstructed defecation. Okay, the results, if you are interested, the resting pressure 40 to 70, lower in female and older people. Length of the anal canal 2 to 3 centimeter. This is done at the time of the resting pressure, 2 to 3 centimeter in female and higher a little bit in male, up to 4 to 5 centimeter in male. Squeeze pressure 100 to 180. Squeeze duration 15 to 30 seconds, and then it will get fatigue and tired, the external anal suture. Cuff reflex should be present. Simulated defecation, increased rectal pressure with anal relaxation. We said that the anal relaxation, rectoanal index more than 1.3, rare reflex should be present. Rectal sensation, the first sensation should be after we inflate the volume of the balloon to 10 to 30 milliliter. Desire to defecate after 80 to 120 milliliter, and the maximum tolerated volume at from 100 to 300 milliliter. Rectal compliance. Okay, and we said that regarding the expulsion test, balloon expulsion test, it should be expelled out within 1 to 2 meter. We move now to the neurological testing. These include actually the EMG, when to do the EMG, what is the significance of the EMG, pudendal nerve terminal motor latency test, PNTML, and spinal motor latency. Okay. Okay. EMG is one of the oldest modality to screen the function of the external anal sphincter. We said that the external anal sphincter is in a state of tonic contraction, and at rest it is contracted. We can ask the patient to squeeze more, and it will shows an electrical activity more. And when we ask the patient to defecate or to push, it should relax. And actually reading the result will give us a clue to if there is a pattern of fecal incontinence, dysfunction, defecatory dysfunction, if the patient have problem in relaxation of the external anal sphincter, constipation, dyssynergia. It will help us in the work. We will show. Actually, we have different type of electrode. One of them is the needle, the oldest type. Actually, a needle inserted in the external anal sphincter, and you ask the patient, you detect the electrical activity at rest, when he squeeze, and when he push. When he push, there should be a relaxation. The external anal sphincter should relax, and we detect. This is the needle. We have surface electrode. Of course, these are well tolerated when we compare it to needle electrode. And we have what we call the anal bulge intraluminal electrode. Of course, as here, we insert it in the anus close to the external anal sphincter. We said that this will help us in the workup of fecal incontinence and obstructed defecation. This is how EMG of the pelvic floor or the external anal sphincter looks like. And here you can see that we have 3 columns. The yellow column is the rest state. In the rest, the external anal sphincter in a state of tonic contraction. So there is contraction over here. Look into the orange one. This is when we ask the patient to squeeze, how the electrical activity increases. Okay, and look when we ask the patient to push, to simulate defecation, the activity decreases and there is a relaxation. While if you see here in a patient, when we ask, this is the green one, is the push one. When we ask the patient to push, we notice that there is, as you see here, elevated in the external anal sphincter pressure, which means that this patient may have obstructed defecation. Also, if you notice here, a little bit here, that when we ask the patient to push, there is increased in the activity of the external anal sphincter reflected in the EMG. So this may indicate paradoxical contraction after pushing, which may be a clue for diagnosis of obstructed defecation and the constipation, the wide range of differential diagnosis. So I hope you get the clue behind the EMG. Of course, it's of an old fashion. Nowadays, it's replaced by the endoluminal ultrasound and the MRI. What else we didn't add? Okay, let's move to within the nerve terminal motor latency test. Okay, as we previously said that the external anal sphincter have somatic innervation. This is through the pudendal nerve, and we have a an integrity called pudendal nerve neuropathy or injury, which is usually after stretch injuries such as during the third trimester of pregnancy, during the second stage of labor, during forceps delivery, the pudendal nerve can be injured, and this will lead to of nerve supply to the external anal sphincter and fecal incontinence. So how we can test the pudendal nerve integrity? This is, as you see, by a bipolar electrode. It is disposable called the ST mark pudendal electrode. It is put, we can put it as in our hand, and in the tip of our index finger we have a stimulatory sensor, and we have recorder a little bit distal, about 3 centimeter distal, and or proximal, let's say. Here is the record, and here is what we do is we do PR, and we go to ischial spine where the pudendal nerve is, and we stimulate it bilaterally. What should happen that at the level of the record sensor over here, there will be a contraction in the external anal sphincter. This contraction will be detected. Any prolongation in the between the stimulation and the contraction is called the latency time, or the prolonged time. Actually, it's normally to be normal to be less than 2.4 millisecond. This is how the pudendal nerve terminal motor latency test. We stimulate by PR, by the stimulator part with the ST mark electrode. We stimulate the ischial spine bilaterally at the site of the at the site of the pudendal nerve, and this will cause contraction that will be detected at the proximal part of the electrode by the contraction of external anal sphincter. So what do we mean by pudendal nerve terminal motor latency? It's the time from stimulation to time of the beginning of the response, which we said it should be less than 2 and 4 milliseconds. The response is the contraction of the external anal sphincter. We said that the pudendal neuropathy, what can happen, which will result, if we have pudendal nerve injury, can result in external anal sphincter injury and fecal incontinence. Okay, it can be prolonged due to pudendal neuropathy or injury to one of its fiber. Of course, there are many limitations. This is an operative dependent, poor sensitivity, poor specificity. Not only that, it's actually normal result if just some fiber are damaged. Okay, this is how it looks like. Okay, let's move to spinal motor latency. The spinal motor latency and the idea behind it is extremely easy. Actually, we said when we talked about the pudendal nerve terminal motor latency, that it can detect patient with fecal incontinence due to pudendal neuropathy. But if the patient have fecal incontinence, but the origin of the neuropathy is more proximal to the pudendal nerve at the sacrum, at the sacral root, so we use what we call it spinal motor latency. The idea, actually, we have a magnetic coil that are placed at the sacral plexus and lumbar plexus. This is around L2, L3, S1, and actually it gives a stimulation that can be detected by the anal probe that we have. For example, we can insert here anal manometry or EMG, and we will detect what we call it the motor evoked potential, and we will have a graph that it's easy to analyze it. For example, if you can see here, in a normal patient, in a healthy patient, a stimulation to the sacral plexus will cause contraction, and the time between stimulation and contraction should be less than, I think, 2 seconds or something like that. Okay, we will find it. But if it is prolonged, as you see here, this is a patient suffering from a fecal incontinence due to back injury. Here you can see this is here the stimulation, the time from the stimulation and detecting, not the contraction. Here we call them the motor evoked potential or MIP. It's short. If it's prolonged, we are talking about incontinence. The time, okay, I think I see it over here. Okay, we will find it. This is what we need for the spinal motor latency, magnetic stimulation over here, anorectal probe in the anus which will detect the motor evoked potential, analyzer, and this is, as you see here, a short time between the stimulation and the evoked potential, which is in a healthy patient. If delayed, that means we have fecal incontinence in a patient with a spine injury that is proximal to the pudendal nerve origin. Okay, spinal motor latency, we said why do we perform it if we have a fecal incontinence caused by injury proximal to the pudendal nerve. We have transcutaneous stimulation of the cauda equina over the lumbar spine. Okay, and sacral plexus. The response actually can be by anal probe. We can detect the response not only in the external anal sphincter, puborectalis, urethral sphincter. We can check the response at this muscle because all of these are innervated by the sacral plexus. Okay, I think I have no value over here, no number provided, but it's enough to say that there is a delay in the motor evoked potential. Let's move to ultrasound for assessment of the pelvic floor function. We come to the modalities that we are familiar with more, and ultrasound, we know the endoanal ultrasound. As you see here, we have an endoanal probe. It can be 3D actually, and we said that it replaced the need for the EMG or electromyography of the pelvic muscle, and actually it is the gold standard for evaluating the sphincter pathology, especially in patients with fecal incontinence. We do not need EMG. Actually, the general radiology information we have, that we know that this depends the structure, how do they look on this depends on the tissue ability to reflect the sound. The more water in the tissue, they permit the wave to come through, so they are more black, they are hypoechoic like internal anal sphincter, while external anal sphincter or puborectalis, they are of less water, they will reflect the wave more, they are hyperechoic, they will look white. So white, hyperechoic, reflects the wave. This is like the external anal sphincter and puborectalis. When we should order endoanal ultrasound, when we want to assess the integrity of the sphincter muscle, patient with incontinence, and we think this is maybe due to sphincter pathology. This is due to fistula, whatever fistula can be, simple, complex, rectovaginal, in Crohn's disease, and also to assess success of surgical repair after surgery. Okay, the technique, the patient should be positioned in the left lateral position, given enemas, two enemas to clean the anal canal, and actually what we see, the endoanal probe is inserted. The tip should be at the level of the puborectalis, I think. Tip at the level of the puborectalis. We said that the puborectalis, which engulf the rectum, will at the level of the anorectal junction or anorectal ring, the end of the rectum, beginning of the anal canal. To analyze, to interpretate the information from ultrasound, we have to divide the anal region to three parts: proximal, middle, distal. In the proximal anal canal, where the tip in the puborectalis, what we will see is the hyperechoic, the white tissue that will be like a C shape that engulfing the rectum, the puborectalis. That's what we will see, as you see in this picture. This is in the proximal anal canal. We have a hyperechoic white puborectalis muscle. If we go down a little bit, we will see the internal and external. It's important to remember that internal anal sphincter actually finished distal than or proximal than the external, which continue more down, more distally. So in the middle we will see the internal and external. We said external is white, hyperechoic, internal is black, hypoechoic. If we go more distal to the distal anal canal, what we will see is the only external anal sphincter. Of course, if we have a fistula here, it will look hypoechoic, and we can determine. What also we can measure by ultrasound is the perineal body, which is between actually the posterior vaginal wall and the anterior rectal wall, and actually it is about 17 millimeter, less than 10 millimeter is associated with anterior sphincter defect. Also, we can measure the length of the anal canal, which we said in female on average it is 3 to 4 centimeter. It is shorter in female, larger in male. In male, from 3 to 5.5 centimeter. We can also assess the thickness of the internal and external anal sphincter. Actually, this depends on many factors. This is nulliparous, multiparous woman, old age, younger. For example, the thickness of internal anal sphincter in female, actually it's between 4 to 5-6 millimeter. It is thicker. The internal anal sphincter is thicker in older woman, while the external anal sphincter is about, actually there's a huge variation between anterior and posterior thickness. The external anal sphincter posteriorly, actually it's between 2.5 centimeter, while anteriorly it is a half millimeter. So it is thicker posteriorly. What information we have regarding the ultrasound more. Okay, we said it measured the perineal body. We said the average anal canal in female. Some literature says 3, some other literature says 4. Okay, we go now to the MRI. Okay, the MRI or the static MRI with contrast fistula protocol. From my previous surgical practice, we push the patient with fistula toward a MRI fistula protocol, which is a static imaging. Actually, it's not the modality of choice to assess the sphincters, falling out of favor when we compare it to endoanal ultrasound, which is the best, the gold standard. It is expensive, and this is again from my own experience in anal surgeries. We do not depend on the imaging and result from the static MRI. We have either endoluminal ultrasound, our surgical exploration, or we have more for other pathology. We have the dynamic MRI, as we will see. This is how MRI looks like. This is the external anal sphincter. This is the mucosa, the anal mucosa. And here in the external anal sphincter, there is a defect here. Actually, sometimes we push the patient when we feel it is a complex fistula and we actually have no access to endoanal ultrasound. This is why we push patient towards static MRI, but never think of it as a modality of choice. Dynamic imaging study for pelvic floor. In this case, we start to talk about defecography. We have different type of defecography. We have evacuation defecography, we have MR defecography, we have the dynamic ultrasound, and we have the echo defecography. This is when we talk about dynamic imaging. Let's first move to defecography, or what we call it, the evacuation proctography and the defecography or dynamic proctography, evacuation proctography. Actually, it's a cost effective and it can assess two main pathology. The first is difficulty in defecation. If the patient has obstructed defecation, we will know how we can detect the cause, and also pelvic organ prolapse such as rectal prolapse, enterocele, cystocele. We can also assess that. This is done actually by, it's a fluoroscopic simple technique, doesn't require that. This is a paste barium thickened a little bit. We can add certain fibers to make it more thickened so it will simulate stool, and we inject it in the rectum and we ask the patient to pass to defecate, and we will take a fluoroscopic imaging. As you see here, we have the commode, the patient sits here, and here we take the image, which can be captured in a still one image or multiple canine loop image. What else we have? Again, it is defecography, dynamic defecography, evacuation proctography, two main indication, obstructed defecation or pelvic organ prolapse. We will discuss what does, or when even to suspect pelvic organ prolapse. Okay, to be just clear, we said that thickened barium paste are given and inserted to the rectum, and we see the gun. This is the gun, how we insert. But to diagnose, for example, enterocele, we said that one of the pelvic organ prolapse is enterocele. This require actually ingesting contrast to take it orally to detect enterocele, for example. How to evaluate, how to look for normal defecography to study it. Let's move a little bit here. This is normal defecography. First of all, we have to see that while the patient is asked to normally evacuate and the patient is normal, the anorectal angle will be increased. What do we mean by the anorectal angle? It is the angle between two lines. The first one, A, it is in the middle anal canal. Where is the letter A? Measurement of the anorectal angle is measured between the longitudinal axis of the anal canal. The longitudinal axis of the anal canal and the C, this is CD or CD, this line is the line parallel to the posterior wall of the rectum. So one in the long axis of the anal canal, the second posterior angle, actually this will be the anorectal, anus, rectum, anorectal angle. When we defecate, this angle will actually, the puborectalis will relax and the angle will be wider. It will increase. This is first. Second, obliteration of the impression of the puborectalis. Actually, the puborectalis here, it will relax and so it will be not seen. What else we have? Wide opening of the anal canal will be also seen here, not closed. This is a normal evacuation. And what else? Total evacuation of the rectal content and normal pelvic floor resistant. What do we mean by normal pelvic floor resistant? Actually, we have a line called the pubococcygeal line. It is the line between the pubis and the tip of the coccyx. This is the, let's say, the defecographic definition of pelvic floor. And so pelvic organ prolapse are based on how far below the pubococcygeal line the organ will descend. To show you where is the pubococcygeal line, I think we have a picture here. This is, I think, the pubococcygeal. Yeah, this is the pubococcygeal line. This is the pubis, this is the coccyx, and how far. We will talk separately about the pelvic descent, but this line we can study by defecography and we can conclude if there is descent or not. So we said the 5 parameter for normal evacuation. Let's summarize it again. Increase in the anorectal angle, obliteration of the impression of puborectalis, widening of the anal canal, and total evacuation of the content, normal pelvic floor resistant. This is based on the pubococcygeal line. Okay, we talked about the anorectal angle and we said the measurement of the anorectal angle, it's in the wrist should be smaller. In the wrist it should be between 90 to 110, and whilst training it will be more wide, between 100 to 180 centimeter. Again, it is the line between the longitudinal axis of the anal canal and the line parallel to the posterior rectal wall. What else we have? We talked about, we said that the pelvic floor defined as the this is based on the defecographic definition. It is the pubococcygeal line. Below it we start to talk about descent, prolapse, we will see, but it is the line between the pubis and the top of the coccyx, pelvic organ prolapse. How far from this line the organ will be down. Okay, to assess pelvic floor descent, to assess how much does the pelvic floor will be descended or the organ will descend, you have to ask the patient to strain without defecation. Okay, is it clear? This is the normal, this are the parameter to look in normal evacuation in defecography. Let's take a look to how does rectocele, enterocele, sigmoidocele, intussusception looks like in defecography, and pay attention that these are just a radiological review of this entity. We will have a separate lecture for these diseases. Okay, let's remember again the indication for defecography. It is obstructed defecation or pelvic organ prolapse, of them the rectocele, which is a weakness in the septum between the vagina and rectum, called the rectovaginal septum, and you can see the bulge of the anterior rectal wall to the posterior vaginal wall, and those symptomatic female may require digitalization or digital pressure to the posterior vaginal wall to complete the evacuation. Actually, defecography is better than the symptom itself to diagnose rectocele. Rectocele up to 3 centimeter in female is considered insignificant. Rectocele can present in up to 95-93 of the asymptomatic patient. You can see in defecography how does the protrusion of the contrast to the anterior vaginal wall. Actually, to diagnose rectocele, we need a evacuation, during evacuation, and the important post-evacuation. As post-evacuation, we will see the trapment of contrast in the rectocele, as you see here. This is pre-evacuation. Okay, this is a rectocele bulge of the anterior rectal wall toward the vagina, and you see post-evacuation the contrast is still trapped in the anterior vaginal sac or protrusion, let's say. Okay, what else we want to add regarding the rectocele? Let's move to intussusception or prolapse, which may present as a obstructed defecation problem. Okay, intussusception and the prolapse, and what I want to pay your attention here, that the new study found that in rectal intussusception and rectal prolapse, the predominant symptoms is incontinence and fecal incontinence, not constipation related symptoms. Actually, as you see here, the intussusception can be intrarectal, intraanal, extraanal. This is how rectal prolapse, we will talk about it in a separate lecture, but you have to remember that it is when I suspect it, defecogram is one of the work up. We have an Oxford grading system. It depends on the degree of the protrusion from the anus. Enterocele and sigmoidocele. This is how enterocele looks like. And here we said that to do defecography, if we suspect enterocele, the patient should ingest contrast. And you see that the small bowel is herniating in the space between the rectum and vagina. This is called the pouch of Douglas, actually. This is how enterocele looks like. This is enterocele. Sigmoidocele also herniation through the pouch of Douglas. This patient will present with obstructed symptoms of obstructed defecation. Sorry for that. Let me go here. You can see enterocele is defined as small bowel between the rectum and vagina. This is the pouch of Douglas, most common after hysterectomy, best seen during straining phase when you are pushing, and it requires oral contrast. The symptoms will be obstructed defecation. The normal intra-abdominal pressure shouldn't descend below the rectum, below the upper rectum. Okay, what do we mean by anismus and pelvic floor descent? Okay, anismus and the opposite of anismus, pelvic floor descent. Actually, anismus is failure of the pelvic floor muscle to relax. For example, the perineum, many names we have: the perineum, spastic perineum syndrome, the puborectalis dyskinesia. The pelvic floor does not relax, so evacuation cannot be completed. This is actually suspected when about two-thirds of the contrast that we give during defecogram cannot be evacuated within 30 seconds. Many muscles we have, so we have many names: anismus, paradoxical puborectalis contraction, puborectalis dyskinesia, non-relaxing puborectalis syndrome, functional defecation disorder, pelvic floor dyssynergia. So, okay, because we have many muscles that may fail to relax. Pelvic floor descent, it is the opposite of anismus. It's actually relaxing, and more than 3 centimeter will be abnormal. Up to 3 centimeter, this is usually insignificant and normal, and actually this is maybe due to chronic straining and constipation. So this pathology we can pick up with defecogram. Let's move to the evacuation defecogram, or we call it the proctography, I think. The evacuation proctography. We can use the same technique but with MRI. This will be called, sorry for rolling, MR defecography. Okay, regarding the MR defecography, it's the same principle of fluoroscopic imaging, the traditional defecography, but using an MRI. You can see that the patient is lying supine, slightly the knees are bent, and actually this is a disadvantage because many patients require the natural positioning to complete their evacuation. This may limit its validity. Actually, one of its advantages is that it is a radiation free, and you can see here this is an imaging show you MR defecography. Here we have sigmoidocele. The sigmoid is protruding through the vagina. Here we have an MR defecography at wrist, and they show the anorectal angle. Here we have, I think, rectocele, the actually rectum is protruding to the posterior vaginal wall. Here we have enterocele. It's clear. This is what we talked about, the pubococcygeal line below it, and to pouch of Douglas between the rectum and the vagina we have protrusion of the small bowel. We said it is no, this is what I want to say, limited validity of the imaging. This is because of the supine position of the patient, which is not the normal position to defecate. Okay, dynamic ultrasound. Okay, the dynamic ultrasound, actually, it's we talked about the endoanal ultrasound, and we said it's the gold standard to detect any sphincter pathology, especially if we have a risk for fecal incontinence. Actually, the endorectal ultrasound is part of the dynamic ultrasound. As you see here, we have three probes: the endoanal image, the endorectal ultrasound or endoanal ultrasound, the transvaginal or endovaginal probe, and the transperineal probe. Actually, the imaging is taken in a canine multiple image and analyzed later. And actually, it's better to detect pathology such as rectocele, enterocele, intussusception, cystocele. This is what we call them, the middle and anterior compartment syndrome. When we are talking about prolapse per se, no, prolapse is better with the traditional defecography to diagnose. What else we can add about the dynamic ultrasound? We said in experienced hand it's more effective in diagnosing peritoneocele, enterocele. It gives us information about the interior and central compartment. When to use dynamic ultrasound? When we have symptoms of obstructed defecation. The echo defecography, we said that in dynamic ultrasound, no contrast, no rectal contrast are given. Just we take a picture during rest and we ask the patient to do Valsalva. In echo defecography, we insert a gel in the rectum and we assess we ask the patient to defecate and we assess any problem of obstructed defecation. It's a 3D dynamic ultrasound, an ultrasound gel in the rectum to assess any obstructed defecation. The technique, actually we have 3 time for imaging. First, at rest without gel. This will help us to assess the integrity of the sphincter complex. Scan number 2, it is also without gel, similar to the dynamic ultrasound without gel, during rest, strain or Valsalva, and during rest. Also, this will assess the muscle relaxation during defecation. If we have, for example, anismus. And scan 3, it is with gel. We take a scan during rest and then during evacuation and then during rest. This is what we call the echo defecography, repeated 3 times, and then we collect the data. Actually, in this modality we use the endoanal, logically the endoanal probe. We reach the end of this lecture. Thank you. Bye bye.